Just a minute, let me share the PPT. Is my screen visible, PPT visible to all of you?
Yes, sir. It is visible, not in slideshow mode though.
Yeah, I do that.
Okay. And sir, before we start off, just giving a heads up publicly that we will not be having any facilitator for this particular session. So you might have to take up the chats as well. Of course, I'll be
All
there
right.
to support you, but just thought I
Right.
will give it.
So I have to manage the thing by myself, right? That's what you are telling.
Actually, sir,
I
I'll
no
be there.
problem. Yeah. No
Uh,
issues, no issues. Shouldn't be a
now we
problem.
are good to go, sir. The PPT seems
Yeah.
perfect.
Okay. So just can I get a brief description about how this will flow? For example, I should talk or will it be interactive? You also shared a case with me, and when that will be discussed?
Sir, it is actually your call completely because our participants are very interactive. So if
Mhm.
you want, you can make them interact in between, or you can choose to complete your talk and then start the Q&A sessions. We are comfortable with anyways. I believe I am correct, our beloved participants.
All right. Okay. That's absolutely fine with me. Uh, just a minute. Okay. Right. So as you rightly pointed out in your introduction, thank you for introducing me, Sri Priya. Thank you. Wonderful to meet you all on this evening. Uh, Great. I'm told that it's a mixed group of participants. Some of you are doctors, some of are students, and some those already underwent treatment. So it's a completely a mixed group. So it will be a tough task for me because it's a one homogeneous group. It will be easy for me to, focus and give example and discuss. But here the topic also not little, very much sensitive. So I think it should be an open, interactive session so that we can exchange experiences. Uh, telling you with code, but it's an exchange of your knowledge. Okay, what I learned and I know, I'll share with you. Similarly, you can share the experience that you had in your lifetime. That will be good. Okay, so this I think you must be ready. This topic, spirituality. We need to understand that what's happening in the world. Little old data, but still I felt it's a very essential data to be shared with you all. 60% of the world's new cancer cases occur in Africa, Asia, and Central and South America. And around 70% of the world's cancer deaths were also found to occur in these regions. That's something very important. So, cancer diagnosis, deaths, if you consider these two, it's happening mostly at the higher level in these regions. That's what it tells you. And India is in the third place. Just look at that figure. It tells you very clearly it's in the third place. Okay. So what are the concerns? So concerns behind the screen. When someone diagnosed with cancer, so what happens to them? So generally we know that fear is the one first strikes every day. So why that fear comes? There are a lot of one. Uh, it's their experience in life. Some it's what they learned earlier, what they heard about the word cancer. So all these matters. So it leads to extreme fear, helplessness, and also to a greater extent psychological trauma. So in psycho-oncology, we call this distress. We say this is a distress. We don't want to use any psychological stigmatizing terminologies like depression, anxiety, adjustment disorders. We don't want, of course, there could be possibility these can, not denying that, but we prefer to use the word distress because it's easy to assess and also less stigma and acceptable by patients and family members especially. So that is one. Second, three inevitable existential problems will take place. One is suffering, the second one is death, and the third one is these are these are very important, especially in the cancer continuum. Whether at the time of diagnosis or when the or the or whether they are in survivorship or end of life. When I say survivorship, the sufferings are there even during survivorship, but in different form. But the end of life care, it is different. Okay. During treatment, it is different. If you ask me whether the patient getting treatment, curative intent, doesn't think about that means no, they do think about that because that strikes whenever they get, very high dose treatment or heavy treatments, then that does come to their mind and they do think about it interfering their day-to-day life. So suffering there in the form of symptoms, also thinking about death, anticipatory anxiety, and all these are commonly reported. And existential guilt, uh, that also takes place in most of the case. When trauma occurs, the spiritual aspects of the individual's worldview and related resources may be threatened. So, what they were practicing until the diagnosis and their view about the spirituality. Here, I think we need to little bit debate. I'll keep the discussion open for a open discussion so that you all can throw your ideas so we can discuss. I strongly believe that the spirituality and religion are two different aspects. So you cannot, you have to differentiate. That is something that we need to discuss. Patients experience both positive and negative spiritual changes during the cancer trajectory. It is not that always people say that God has not helped me. I did always pray God until these years, and why it is to me. What I have done, I have not done any sin or any mistakes in the past. Why should this happen to me? All these questions can come, but still they continue to pray God. But still, oh God, I continue to pray you, please do save me, help me to cope. But there are someone who still raise a question. I did all this, but you still didn't help me. So why should I pray? Why should I continue? It has not helped me. So the both the angles you need to look at it. So if you look at this, the picture right side, demoralization. So when a person gets demoralized, when these things happen, when they feel helpless, when they are hopeless, when there is an existential despair and desire for death, loss of meaning in life, all these occurs when the person has no hope or hopelessness. So this is when it really raises question. Okay. Then coming to spirituality. So I halt here. I'll go to previous slide. I want some of you to tell me what is your understanding about spirituality. I'm sure you will be having some experience when it comes to spirituality. So what do you know about spirituality? What is your take on spirituality and cancer? So let's start the discussion with from your end. Can some of you unmute your mic and speak? Or should I name you?
The very fact that you believe in something which is not seen, or the belief that it is not just a body, there is a spirit, uh, is something like that is spirituality.
Okay, so you believe, come again, sir. I think Swaju Thomas, sir, please.
Yeah, beyond the body, like there is something other than the body, which is you. There's a spirit. The belief that there is a spirit,
Mm.
and basically having faith in something which is not seen by you.
Mm.
There is a
Having faith, not seen by.
higher
Mm.
being that controls the entire world.
All right.
That
Yeah, go ahead, please. You want to add something? That's it?
that's it.
All right. So anybody else? I think Indra Chowdhury unmuted your mic. You want to say something?
No, I just wanted to say that these spiritual practices, whether they are meditation or these other things, these need not be related to religion.
Mm.
I can be born into a certain religious practice, but I can find some other way in which I explain the spirit or my, relationship to the universe. So I think there is something that is spirituality. I mean, of course, there's spiritual dimensions of religion, but all those rituals and all may not be spirituality.
Yes. Okay. So the religious beliefs need not to be interfering with spiritual practices. That's what you are trying to tell. Whether it is yoga or meditation or breathing exercises, whatever it is. So need not to be associated or connected to any particular religion. Is this what you meant? Am I right?
Yes, yes.
All right. All right. Okay. So there are two takes. One is it is beyond the body. There is a spirit and faith not seen by us in in our own eyes. So, but we still believe it. That's what Mr. Saju Thomas said. Whereas Indra Chowdhury ma'am said uh, spirituality and the spiritual practices are completely different from religious practices. Maybe interconnections, but even if there is a connection, it should be looked separately. That's what he's trying to convey to us. Thank you so much. Any other? Anybody else? In case if you're comfortable in your own language, please speak and somebody can translate to me. Uh, that's also possible so that we can communicate well. All right.
Sir, I am Shalaka.
Yes, madam, please.
Hi. Uh, so I am a patient of a fatal and progressive condition, and I also work with thousands of patients around the country. I run a patient organization, and I also happen to be a staunch atheist, and I've never understood spirituality. When my
Okay.
diagnosis happened, I'm so glad that I was an atheist because I did not waste time on things like why this happened to me, what could it mean, who is punishing me. I focused on the logical next steps, the more practical side of things. And I also understood that mental health was important. I did not, take that aspect away. I also understand the importance of meditation, scientific meditation, yoga, all of those things. I still do not understand how spirituality comes into being of these things. Rather, and I've seen religion being a big hindrance to people's acceptance of a disease and how they navigate the disease.
Agreed.
It's a huge, huge hurdle.
So
But I do understand and accept that people do have spiritual needs. I do not understand what they are, and I hope to understand this to you today. And I do feel that they take a lot of comfort from the spiritual aspects of certain things. And your session today is a starting point for me to understand the subject, and maybe my work will, have more value for the patients I serve, my fellow patients after this. Thank you.
So agreed. So what, Shalaka, there are two things I want to get it clarified. You said I am a patient. Are you still a patient? Are you on treatment?
Yes.
Okay, right. Then that's fine. Sometimes those who completed also say that they are patients. So
So by the way, would it be possible for you to focus on not just cancer, but just make it a more generalized thing, because
All right, done.
that's
Because my experience
I,
is only from cancer, so let me try
sure,
to make sure that we focus
I'm
on
sure
other areas.
I'm sure your principles apply universally to
Anybody?
patients with diseases.
Exactly. Right.
I have a
So,
pulmonary and cardiovascular disease that I navigate, but
okay.
that's okay. I mean, whatever else you could bring up. Yeah, thank you.
Understood. Right. Thank you so much. Thanks for your input. And second, you are trying to say that, again, similar to what Indra madam said, you are also saying, you said you are an atheist, right? Okay, you don't believe in God. All right, good. So not necessarily that, those who don't believe in God are not spiritualistic. So that's what I made a very clear point earlier. There is a difference between spirituality and religion. We need not to link these two because this is completely different. Anyway, our focus will be on this. Anybody having points, please share it in the text box so that we can take up for discussion later end of this session. So coming to this slide, the spirituality, I'm not explaining that first line, please, that quote by, Puchalski. So just read and understand that it is, of course, the experience of transcendent meaning in life. That's what, our own inner life. We are trying to find meaning in, meaning in life. That's what everyone tries to understand. Of course, you may have faith. The faith it can be anything. Okay, so your faith may be with God, or your faith may be with your parents, or your faith may be with the treating doctor, your faith may be with something, but generally, globally, when it comes to faith, it always related to a religion. So I'm not touching upon that, but faith, you can relate it to whatever the faith that you have. So I'm not pointing anything to any religion. Number one. So really, spirituality is a broad concept going beyond the limits of religion, which I stated very clearly in the beginning as well. Faith plus religion and religious beliefs. I'm not denying that. Okay. I don't know whether it is fortunate or unfortunate that you all should answer me. That's why earlier also I said it's a very sensitive topic and the debatable topic. And meaning, so when we go to meaning, component of spirituality appears to be more universal concept that exists in religious or non-religiosity identified individuals. So it doesn't mean that you must be associated or connected with any religion. Okay. So spirituality concerns a sense of connecting with others, transcendence, and finding meaning and purpose in life. So this is something that we need to think about. In the last 50 years, if you look at the medical model or in the modern healthcare, there have been increasing number of attempts to discover more holistic approach to care, and we call that as a humanistic approach nowadays. Okay, so whether it's a healthcare provider or the receiver end, we always look for a humanistic approach. That's what we look for. We want to look at the man or a woman as a person, not as a patient. That's what this conveys. So that is what now everybody around the globe is working towards. New policies are keeping it on high. So ultimately, it is not only the treatment, the medical aspects of the treatment. There are so many other aspects that we need to incorporate. One such is uh, spirituality. So you can't deny or you cannot ignore. There are ample evidence to state that spirituality does help an individual in coping with suffering. So whatever the suffering may, I put the word suffering. That can be pain, that can be emotional trauma, it can be stress, it could be anything, but it does help in coping, but not necessarily for all, but majority feel good about being spiritually connected. Okay. So why spirituality in oncology? That's the next question. So look at this slide. So need for spirituality in oncology when it comes to cancer care. Existential and spiritual issues are at the front line. Upcoming clinical and research focus on palliative and supportive care of cancer patients. Physical, psychological, and spiritual domains of end-of-life care have been identified as priorities both by medical professional organizations and by cancer patients themselves. Okay, so what happens? Look at this picture. When the spirituality is lower and the demoralization goes on the higher side. Similarly, when the spirituality is lower, the demoralization may result in depression or more or high level of distress. So that's why the spiritual aspects of coping need to be paid attention, and we need to help our patients, our carers, and the family members. Not only family members, also healthcare providers. Also, the healthcare providers, they do need to cope with such spiritual connectedness. So the need for intervention addressing spiritual suffering terminally in cancer patients, depression, hopelessness, and loss of meaning, an impact on desire for death, demoralization, all need to be discussed and addressed. This is something very less. So religious involvement, salience, motivation helps the person to have less feeling of depressed. Okay, so there are a number of literature available on this. You can Google or you can search in the Google Scholar. So religious beliefs does help. I don't deny that. Religious conversation do help. There is no doubt about it. So, okay, the meaning for suffering and okay, in illness, facilitate acceptance of their situation. And we have ample classic cases about religious practices and how it interferes the treatment and the treatment outcomes. There are a number of experiences that we have, and people, not accepting treatment and insisting to follow certain procedures while delivering treatment modalities. So these are all there in the practice. We can't deny that. Sometimes that has both the end. One is positive, the other one is negative. When somebody is not accepting proceeding towards the treatment, and that may result in failure or progressive disease, ends up in death. That's also there. The other way around, some they accept, proceed, and they come out, cope well, have a good quality of. There are two ends. We need to agree upon that. Then spirituality and quality of life. Of course, ultimately today, everybody talks about quality of life, whether at the time of diagnosis or during survival or during end of life, everyone talks about quality of life. And no trial without quality of life. If you look at any trial in cancer treatment, I think even in cardiology, people do talk about quality of life because all other aspects, even HIV, AIDS, everywhere, everybody started talking about quality of life. That's why the WHO has that, the 5-dimension quality of life scale for all population, not only for specific to any particular category of population. So it is for all. So ultimately, for everyone, whether you are a cancerous patient or any other ailment or general, public, quality of life, the well-being of an individual is more important, and the well-being and spirituality are very much connected, very much associated. And if these two are associated, and if your spiritual well-being helps to have a general well-being or improved general well-being, then that results in improved quality of life. So that is something that we need to understand. And spiritual or religious beliefs and practices create positive mental attitude. That also, it is proven scientifically. I'm not talking based on experience. I'm talking based on the available data. It helps a patient feel better and improve the well-being of family caregivers as well. Most of the time, the person who is caring for the patient is ignored, or they are not being attended. They do suffer. If you ask me, from my experience, more than the patient, the family members, the caregiver suffer a lot. Their suffering is something which is more, and there are less people to attend to them. So at least with the patient, the doctor speaks to them. There are other people, other social support, social mechanisms which helps. Whereas in the case of caregiver, it is less. That's why now the caregiver support mechanisms are increasing. So improving health and quality of life. So how to improve quality of life? So through spirituality. That's what this slide is about. When you are spiritually connected, when your spiritual practices are improved, that decreases anxiety, depression, and discomfort. Okay. Now here is a question. If someone is clinically depressed, can the spirituality help? No. That we need to be clear. So not all depression or clinical depression, or I may be sad today. It doesn't mean that I'm sad all throughout. So you need to differentiate. Okay. So somebody who is feeling sad, somebody who is experiencing anger, these are part and parcel of life. It may not last for longer time. If these symptoms last longer, more than 2 weeks, or then you need to pay attention. It affects your day-to-day living. Then that's again, it's a big question. So that is when you need to pay. But generally, when you experience this, when you start practicing spiritual practices, that really reduces this. One. Then it decreases isolation. Most of the time, what happens if you are a working person or if you are a socially well-connected person, when you are on treatment, when they are on treatment, then what happens? The loneliness will take them for a toss, feeling alone. At times, that raises question: are there nobody around me? Okay, so these questions will come. When they have spiritual practices, that reduces, decreases. I see, look at that. It is not going to completely elevate, but it's going to reduce that suffering. And also, if someone is addicted to any substances, that also decreases. It lowers blood pressure and the risk of heart diseases, reduces the risk of heart diseases, help the patient adjust to the effects of cancer and its treatment, increase the ability to enjoy life during cancer treatment. These are all very evidence-based, okay, and give a feeling of what to say, personal growth as a result of living with cancer, increase positive feelings, including hope and optimism, freedom from regret. Of course, regret can take place in any form. We don't know. It depends on the individual, how they perceive the whole process. It depends on that. Satisfaction with life, sense of inner peace. That's what everyone strives for, trying to achieve that inner peace, whether irrespective of you're a patient or you're a not patient, everybody for that matter. As far as we are not dependent, when I say dependent, the soon we complete school, until we complete the school, we are dependent. After that, we are not dependent. Okay, we become independent in most of the sense. Okay, so we are not bothered about anything until our school days. Whatever we want, we get it from our parents, and they look after all our painful feelings. Even if we have sufferings, we tell them, they take care. So when they become dependent, all the suffering takes places. That's what I'm trying to tell you. So there is a word called spiritual distress that may also affect health. It has been defined by this NANDA, it's a North American Nursing Diagnosis Association. They define the distress. Of course, you need to differentiate between the general distress that we talk about, also the distress, the spiritual distress that has been already defined. It has been defined as the impaired ability to experience and integrate meaning and purpose in life through connectedness with self, others, art, music, literature, nature, power greater than self. Please read it again. The definition very clearly explains impaired ability to experience, okay, and integrate meaning and purpose in life through connectedness. if you fail to do this, that's going to be spiritual distress. If you are able to connect well, experience this process, then you will not have this spiritual distress. If not, they will go through spiritual distress. That's what this means. Then spiritual distress may make it harder for patients to cope with cancer and cancer treatment. Healthcare providers may encourage patients to meet with experienced spiritual or religious leaders to help deal with their spiritual issues. Unfortunately, in our country, our healthcare providers do not have sufficient time to send with the patients and the caregivers to talk about the disease itself. Do you think they will have time to talk to you about or talk to the patient about the spirituality? And if you ask about something related to the disease during survivorship, also doesn't have, you can't blame them. The number of patients dealt by our physician is much higher when compared to the West. There they see 10 to 20 patients in a day. Here our doctors see 90 patients a day. So the load is very high. So I think we should look at their aspect also. So religious and spiritual coping. And I think to be on the safer side, I'm talking about religion. And I'm sure you'll have hundreds of questions about religion. To be on the safer side, I'm not telling that religion doesn't help you cope. It does help you to cope. But here our focus is on spirituality, not on the religion. Okay. Patients resort to religious or spiritual coping when other coping techniques do not provide solace. Okay. So what is other coping strategies? Can anybody tell? What is adaptive coping? What is maladaptive coping? Someone uses defense mechanism, someone uses denial as a coping, someone uses acceptance as a coping, someone goes and drinks, someone try to be isolated. They isolate them, they don't talk to them. There are different ways of coping. Okay, we are not talking about that. That is a process. But here the spiritual coping is something when you do exercises, when you do breathing exercise, when you do meditation, when you do other forms of spiritual practices, that really helps a person to cope well. So that's what it means. And commonest coping among cancer patients in Indian culture is the religion and karma. And generally, I think we all need to discuss. There is a question, why me? I never done any mistake in my past. Throughout my life, I practiced very well. I go to temple, I go to church, I go to mass, and I practice perfectly. And I never missed any prayers with God. With all this, but I still got cancer. Why? Okay, and somebody say, no, it is because of your karma. Okay, so karma, what is karma? That's again a debatable one. Some say it is not you, it is your forefather, or it is maybe in last, the previous life of you would have done some sin. That's what you are experiencing. All these are our own. But if you ask me as an expert, I would say these are meaningless. Okay, these are our explanation to religious coping, but that's not, we don't know whether still there is an existence of that. We are living in 2024, but I'm not telling that you don't believe it. It's your belief. I respect you. You can you can tell your patients to continue to practice that. We have that freedom. You should give them all those things. No doubt about it. Okay. So positive religious and spiritual coping, acceptance of illness and purposefulness. So that's what it gives you. Negative coping, what happens is religious and punishment by God. If you think that the karma has punished you, that's going to result in distress. That's going to lead to confusion. That's going to lead to depression. And if you think whatever happened it's happened just like that, accept, then that when it comes to acceptance, that's going to help you and you are going to find purpose and meaning in life. That's what the positive aspect of spiritual coping. Okay. There are evidence. There is a study they conducted on pain control methods. So 62% of the patients reported that they use prayer as a method of, to cope or control pain. Okay, in addition to pills, still the pills, the number one. Okay, medication remains number one, but prayer also on par with that. That's what I'm trying to tell you. So I've given the reference also. You can also read about it. So, okay. So it is by the McNeil. He's the one conducted study and reported that 62% of the people use prayer as a mechanism to control the pain. You agree with me? Okay. So there is a growing recognition for the spiritual practices when faced with suffering and threats in life. Patients frequently articulate spiritual concerns. So it is very important to know our patients. It's greater attention paid to religious values, and don't argue. If somebody says that this God is helping me, please accept it. You don't need to bargain. You don't need to tell them no. It is their right. It is their right to practice religion, right? So that understanding as a therapist we must have, and the beliefs. The belief is something that nobody can touch. The values is something that nobody can touch. Okay, so that's why we say acknowledge. That is something very important. Okay, and heal your patient, integrating spiritual and issues of meaning and faith in the supportive care of cancer patients with advanced disease, essential component of optimal supportive care. So if you talk about supportive care, a supportive care without spiritual coping is not optimal. It may be suboptimal then. Okay, that's what I'm trying to convey to you. Maintaining sense of meaning, peace, and hope in the face of advancing cancer. See, when you tell somebody that your disease is progressive and no further treatment possible, finally, generally they say only God can help you. This is the word they use. But it is equally important to tell them that, please, there are so many other possible ways in which you can cope. Some of them are like, non-traditional, alternative, spiritually based interventions, grounded in theoretical perspective, ranging from yoga, meditation, Buddhist philosophy, and all those things. Ultimately, you are aiming for meaning in life, right? So this opens up further discussion on what you need in the remaining days of your life. This is what lacking in the end of life care, I would say, which is to be paid attention. Okay. There are evidence-based approaches. Spirituality has the substantial effect on quality of life. It does improve the quality of life, which I have already explained you. Spirituality preserves patients' quality of life despite severe physical symptoms. Okay, and even if they are suffering from pain, if they have spiritually connected or practices that helps them to cope well, that's what it means. Spiritual well-being and meaning. So it's a buffering agent protecting against depression. I told you clearly, the clinical and the other aspects of depression. Hopelessness, hastened death among terminally ill cancer patients. Almost 40 to 95% of patients want their physician to be attentive to their religious and spiritual concerns, particularly in the setting of terminal illness. Okay. But it's $1 million question. Do you think we will have, they will have time to talk? Maybe, probably things will change in future. That's what the current guidelines are talking about. When they talk about humanistic approach, probably they will sit and talk also about the spiritual aspects of coping. Increased spiritual support from the medical professionals results in improved quality of life. That results in increased satisfaction with medical care, reduced aggressive end-of-life care. The meaning-centered therapy is being used as a number of palliative cancer centers in the West. It is applicability and usefulness in Indian setting is yet to be proven, okay, or unproven. So generally, there are less number of studies which are conducted in the religious, or spiritual aspects. No much study. Even if you look at the presentation which I made, only 6 studies are available, 6 to 10, not more than 10. It's less than 10 studies available. Okay. Now I halt here. Any questions on what we discussed so far?
Sir, I have a basic question.
Yes, madam.
I did not understand transcendence. What does it mean?
Sorry?
What is transcendence?
Transcendence is one's own understanding, trying to understand one's whole inner self to attain meaning in life. That is transcendence. It's very difficult to understand that. So of course, what we look for life is a meaning, the purpose in life. The very purpose is what transcendence.
Is everybody's ultimate goal meaning in life?
I'm sorry?
Is everybody's ultimate goal in life the meaning of life?
Of course, there will be. It depends on the individual. Not necessary that all must have the purpose in life. It depends on the individual. If you ask me as an individual, the number of person having purpose in life is much lesser than those who have meaningfulness in life. And the same, if you look at Maslow's hierarchy of needs, if you compare this with that, there we got stagnated with esteem needs. We never move forward. There is a self-actualization. And when does that self-actualization comes? Only when you know the meaning and purpose of life. You need to connect it with that. Okay. So if you are stagnated with the materialistic world, you won't think about all these things. What is materialistic world? Money, your esteem. I have this power, need for achievement, need for affiliation. These are all materialistic things. If you go beyond that, then probably you look for purpose and meaning in life. Only few achieve that. It doesn't mean that all of us don't have, but we don't pay attention to that. That's the important part of it.
So I also wanted to say that, when we're talking about karma, and I found that in my work, karma is the most toxic concept. The most toxic concept. And you also said that, when somebody expresses their religious beliefs, you have to accept it, acknowledge it. I agree with you. But when it comes to the concept of karma, and when I hear other patients talking about it, we try to put a stop there, because we try to counsel the patient that karma, that this kind of, because it's game over. When you start believing in that, it's game over. You will never try to get better. You will never try to, improve your condition, or, try other things, or, you won't even try to cope. So I've seen patients being suicidal because of somebody feeding into the brain that this will happen to you because you must have done something, in the past life, or that.
Inducing the guilt.
Yes, it's the most toxic thing.
Yeah.
And me and my, fellow patient leaders, we always counsel patients to get rid of that concept.
Right.
In whatever way possible. We don't care who they go and if they have to go to talk to a psychologist to deal with it, or talk to us again and again, or rethink your worldview. But this karma concept doesn't work at all.
All right. See, there are two things to look at it, ma'am. One is, of course, what you said as toxic, the karma discussion, all those things. These are unavoidable because we live in a multicultural society. But this is beautiful, actually, when we say multicultural, multilinguistic society. We are living in a very beautiful setting where we respect each other. Unfortunately, what happens if this is not taught properly during the childhood, the brought up, and people around, when they come up with such a personality, that will interfere the other person's belief system, value system. So the way we respect our values, our beliefs, the same way we should respect the other person. So that is what very important aspect of personality. But no, I understand. But what we need, instead of thinking about or going to a psychologist or a spiritual guru, as an individual, we ourselves can cope with this. Only thing is we need to learn to be assertive rather than being submissive or aggressive. Aggression is like, expressing your negative emotion. Submission, being submissive is like, controlling or suppressing your emotion. Express your feeling without hurting the other person. That's
So
what assertiveness.
patients, when they start discussing these things, they're relieved that maybe it is not karma. Because once you believe into that concept, you're just devaluing your own self.
Yeah. So probably if you are a therapist, if you are dealing with the patient, probably you should pose the next question that what made you to think so?
Yeah.
So use the Socratic questioning. That will help them to come to a realization, make them think. That's what a therapist should do. Okay, it's not that leading the conversation in an argumentative way. Rather, we should help them understand, make them realize whether they are in a logical thought process, much needed one.
Yeah.
That is something.
So when we counsel patients, we try to take them towards, what are the positive things that you find in your religion? Where do you find that? You look for hope, you look for support, you look for those things. And maybe rethink what you believe about karma also, because I'm not very clear about karma, so I will not even comment on that aspect. What I only tell them, don't believe that, you have no value anymore, that there's no fight to be done, that your journey ends here and everything is destined.
So that's what. So to sometimes what happens, you can't go beyond certain extent. There you should stop or you should withdraw, halt, and then see. Okay, probably if you tell them the options, probably when they require, they'll come back to you. That is something. Okay, right. I halt here. Thank you for interaction. And now coming to this, see, we were talking about from the beginning, spirituality is something that is scientific nowadays. There are reports. So please remember, when you talk about scientific nature, it has to be assessed. So you need to assess scientifically. Are there any tools to assess this spiritual nature of aspects? And so it can be assessed by the doctor or with a healthcare provider. There are tools which are available. But the available tools are which are longer one. We don't have a shorter version. But generally, I would say whenever a patient comes to a hospital, any patient with any condition should be assessed for spiritual coping. So the simple questions that can help open up conversations are, do you have any spiritual or religious beliefs that are important to you? How do your spiritual beliefs influence how you cope with your illness? This, something like that, you can post questions. So from there, you can take up and continue the discussion. So this is something important. There are tools available. FICA is a one spiritual history tool. It has 4 domains: faith and belief, importance, community, address and care. These are all the 4 domains. And hope questions. And if you look at this, the sources of hope, organized religion, and the personal spirituality and practices, effects on medical care and end-of-life issues. These are available tools. And spiritual history tool is available. It's called Spirit. And then, if you look at other tools, Breathe or Cope, that is the religious coping questionnaire, and spiritual well-being scale is available, and URTC SW32. And this SW32 we have recently validated and translated in association with URTC. That's also available in India now. So these are all the tools that's available, which you can use to conduct research in India. So I'll just quickly take you through this so that we can discuss further. In developing countries, it is well ingrained cultural, traditional, and family values. And if you look at India, no need to ask anything. We are already practicing these aspects extensively for thousands of years, I would say. Medical and comfort research may be limited. Economically, impoverished, low education and resources, and religious and spiritual lifestyle. India, see, people go to temple, people go to church, they practice, but when they are diagnosed with some diseases like this, then there is a lot of question. Whether everybody copes well with spirituality is a big question. So patients seeking refuge in holy or religious places to obtain mental and spiritual solace while awaiting death. It is very common in India, I say. Not all, but some. Traditional palliative care in India with customs and rituals practiced through the ages with home-based spiritual and religious care for the dying. And that's also there. And we, even in our institute, there are religious groups. They come and teach our patients about various systems. It's not one particular religion. There are many. And similarly, yoga, meditation, and devotions, and all these are there to cope. It is available. Okay, so I just skip this slide. Okay, so there are therapies unique to Indian context, considering the cultural element. Pranic healing is there, and yoga is, you know very well that yoga is another practice that can be followed. Pranayama, transcendental meditation, and Sudarshan Kriya yoga, music therapy, Tai Chi, Reiki, aromatherapy, Ayurveda, and naturopathy. Nowadays, if you look at music therapy, art-based therapy, art therapy, there are so many other forms of therapies which are available. So we have done a quick review of studies using these keywords: end of life care, spirituality, spiritual coping, palliative care, quality of life. So there are 6 studies, Indian studies, which were identified with cross-sectional studies, and some of them are qualitative and quantitative mixed methods. Patients with advanced cancer in India, focusing on spiritual concerns, incorporating spirituality in the care. Only 2 studies met the inclusion criteria. See, if you look at the major findings, is depression, anxiety correlated negatively with spiritual well-being. And you know what is that negative well-being? If this is more, that is less. One is on the higher side, the other one is that is a negative correlation. It doesn't go in, inverse relationship. Spiritual well-being closely correlated with both physical and psychological indicators of distress, very highly significant. Okay, that's what they say. Spiritual well-being was identified as a main component of quality of life in advanced cancer patients. So these are all the findings of the study. So this is what about patients. Just quickly to address healthcare providers and spirituality. Multiple studies suggest that most patients want their healthcare providers to address their religious. This I've already told you. Similarly, healthcare providers also go through a lot of problems while handling patients. Nurses, doctors, other technicians, everybody go through problems. They do need support. So it's very important to assess the spiritual or religious aspects of coping. I would say I will stick only to the spiritual coping for the healthcare providers also. And there are studies conducted, but not in length like what it has been done for patients. But whereas for the healthcare providers, it's much, much less. So what are the findings of these researchers? One is the person, attitude towards patient's spirituality. So 35% of the nurses showed high level of spiritual competence, and they provide spiritual care to patients through unprejudiced respect for their religious and spiritual beliefs, open and trying to impose their beliefs. Okay, not trying to impose their beliefs. That's something very important. 35.9% of allied healthcare providers had an average competence, better communicating pertaining to their religious and spiritual or other aspects of coping, and accepting attitude when compared to oncologists and nurses. So the allied health professionals are much acceptable than the other one. That's what it says. Assessment and implementation of spiritual care. Allied health professionals, around 29.1% were highly competent to evaluate, assess, and understand spiritual needs either orally or verbally, and could tailor make a spiritual care plan for them. Referral. When it comes to referral, allied health professionals had an average competence. It's only 29.1% because they couldn't refer. Personal support and patient counseling. Nurses had high spiritual competence in providing spiritual care in consultation with doctors and medical team during physical care to carry out daily spiritual practices. Professionalization and improving quality of spiritual care. Allied healthcare professionals, in comparison to nurses and oncologists, had an average competence and quality assurance in organizing and implementing workshop conferences regarding coaching other care workers in terms of providing spiritual care. So irrespective of age, gender, healthcare professional groups, years of experience in India provides exhibit more than average spiritual competence. So it's a clear-cut indication that our professionals are competent to deliver the spiritual care. Nurses and allied care professionals showed better spiritual competency when compared to oncologists, doctors, and physicians. Although healthcare providers show spiritual competence, they lack in certain areas of competence, attitude towards patient spirituality, assessment and implementation of spiritual care, and personal support and patient counseling, which could be the result of limited awareness and training. So still there is a need of more awareness. So what is the way forward in our way? We need to improve the doctor-patient relationship when it comes to spirituality. Who provides this care? That's a question. There is no clarity because you cannot appoint a spiritual person to help them to cope. Already there is a resource crisis in every center. This is again $1 million question whether we can add this. So how to do this? Conceptualizing and measuring spirituality. So I already gave a brief about there are scientific tools which are available so that you can assess spirituality. Lack of trained professionals, and there is a need for more qualified and trained professionals, not pseudo one. I'm talking about those who are literally trained. That's something very important. So pluralistic culture, religious culture, which I think we discussed already. That's also there. We need to be very careful about it. Coordinating with the religious communities. There are so many religious practicing people, value-based practitioners are available. You need to identify and support them in delivering these aspects. And needs some clarity on spirituality versus religiosity. And there should be some provision for spiritual care in any healthcare setting. It is not only cancer setting. In any healthcare setting, there should be some, provision for that. So coming to the conclusion, despite the difficulty in clearly defining and measuring spirituality, growing literature describes its importance in oncology, especially in end-of-life care. Studies show that while clinicians such as nurses and physicians regard some spiritual care as an appropriate aspect of their role, patients report that it is not adequate. So having support from one's religion appears to be one of the most important factors responsible for successful coping with the stress of caregiving. Inadequate scientific research on these complementary and alternative methods casts doubt on their effectiveness. Of course, that's why more research is warranted in this area. Physicians need to be mindful of research showing that religious beliefs and spiritual practices can be useful to many patients and their caregivers coping with the impact of cancer and other diseases. Okay, these are some of the references. I stop here. This is what about my presentation. And I gone through the case that I think some of you, I stop here. I think someone shared a case. I saw the detailed
Yes,
case.
sir. Miss
Yeah.
Indra had shared a case with us.
Yes. And would you like to discuss now? Before we move on to that, I want you to ask questions based on my presentation. Let's discuss for 10 minutes, then we take up. We have 30 more minutes. So we can discuss 10 minutes, then we can take up the case. 5-minute presentation, then discussion further.
Sure, sir.
Can I ask a question, Dr. Surendran?
Please.
Yeah. So, if I look at some of, people who have had cancer among people I know, in the US, there are organizations like Commonweal, which, has doctors like Rachel Naomi Raymond, etc., who are also trying to change medical curriculum. And there are ways in which they sort of discuss not just the options, but also spirituality.
Awesome.
And much of the basis of that spirituality originates in India. I mean, whether it's Buddhism or whether it's Zen, I mean, it originates in the East. I don't know why we cannot adopt something like that, adapt rather, not adopt, something like that, which would give some relief to spiritual suffering.
Yes, madam. You're done? Can I respond? Yeah. I completely agree with you. And even the topmost cancer center in the world, whether it is Sloan Memorial or MD Anderson, they not only have medical, surgical, radiation, pathology, they do have complementary therapy clinics. When I say complementary clinics, if you go to Sloan Memorial, I think they have dedicated yoga clinic, meditation clinics, and they have Reiki therapy and whatever you said, spiritual. All these are available. It is up to the patient to make use of that. They don't force anybody to go to these clinics, but these are available. But as I told you in my presentation, but how far in India we can incorporate into the routine practice is it under question right now? Probably in future, yes, it may come to us. Our patients will benefit from this, I'm sure. That's why I said initially humanistic approach, not just the patient doctor approach. We need a humanistic approach. We need to understand the patient as a whole, not as a part. All right. If no questions, there are some questions in chat box. Thank you, Aparna. I agree with you. Adapting is good, maladaptive is not good. But it depends on what do we mean by maladaptive. What happens sometimes youngsters, they go, whenever they are stressful, they go drink, smoke. That is also maladaptive coping. That is not acceptable. To me, if you consider denial as a maladaptive coping, that is good, I would say. To be empathetic, if you put yourself on a patient side, you cannot say that I have my own right to be denial, I should deny. So how can you say that's wrong? So if we debate as a mental health provider, I would say we should not say this is positive or negative. We say it is acceptable. That's one point I want to clarify. Thank you for the comment. And what else? Okay. Then this is very limited plus karma. Okay, again about karma. Then Aparna, personally, I believe in karma at a very personal level, like how spiritual concepts are supposed to be taken. I do believe if I do good, have good karma, good things will follow, but it cannot be transactional. Okay, like if I do this good things, it will result. These are all belief system. I don't deny. I agree with you, but that's your belief. You cannot say it's my belief. I think that's not relevant to me. And I want you to respect that. That's what we teach. And as a therapist, I cannot say that, oh, Indra, it is your karma. No, I'm nobody to talk about your karma. And if you say it is your karma, I understand, I acknowledge your feeling. There ends the matter. I think that clarity we must have as a therapist. Hope you agree with me. Yeah. Aparna, I think you should unmute and talk. You post a lot of nice questions. All right. So I know. Can you clarify, Aparna P? Can you unmute and explain that question? Just as
Yes,
we.
uh, thank you, Professor Surendran, for the session. My question, I think, is pretty simple. Just like we have midwives for childbirth, apparently there are these professional doulas who help in as part of your final journey, and they help prepare the person who's dying as well as the family for this aspect of their life where they're going to move on from their earthly realm, supposedly. So, in that sense, do these doulas help with spiritual aspects like acceptance, forgiveness, detachment, letting go, and preparing for the inevitable? I think it's pretty self-explanatory.
What is your take on that?
I don't have a take, doctor. I'm sorry, professor. That's why I asked this question because
All
I'm
right.
not a fan of spirituality.
All right. So I'll tell you, when you're talking about death, so that's why I'm just talking.
Yeah.
It does help. Okay. We should open up. And I started my career as a palliative care professional. I started as a palliative therapist in 2002, seen thousands of patients. It's not that easy to open up discussion when it comes to death. You cannot, in India, it's not that easy. Okay. And making someone accept, of course, the birth of religion itself, it is believed that emerged out of fear of death. Okay. Hope you agree with me. The people started talking or forming religion because they felt, feared about death and dying. That's how the religion, the concept of religion emerged, if I'm right. Probably if you Google through or if you read more readings, that helps you. So it's not that easy to discuss. But if you have the competency, if you're competent to discuss with your client about death and dying, acceptance of death and dying, that is super. There are very few midwives, oncology nurses have done it, and they've done. There are very good articles available in this aspect. They only helped us understand the process of dying and end of life. Okay, and there are a lot more to do in end of life because we all look at only two aspects across the world. One is suffering. When it comes to suffering, pain, other symptoms, and symptom management. The second one is legality. Okay. And there is something, the third one, that's what you are indicating actually. Acceptance. Have they accepted death? If you see 100 patients, how many would accept? Second, uh, you're talking about forgiveness. Of course, yes, I did this in the past. I want to talk. I want to call my friend, or I want to talk to my mom and tell this. How many do that in your practice? That's a question. But as a therapist or as an individual, if you are able to bridge this, then you are a wonderful person, I would say. That's my take. Hope I answered your question.
Thank you, Professor. The reason I asked this question also that there is this Indian Association of Palliative Care, and they are hosting a course, 2-day course on how to be a professional death doula on 8th and 9th of June. So that was another reason for my asking this question, that do they really help in this dying process?
Right. Please, you can share this, and maybe, no, I'm not aware of that. Thank you for the message. But I'm very, to my personal opinion, it is much needed area that has to be touched upon. Any other question? Actually, I've started, should I answer this question? This is very personal. I think Shalaka Prabha, right? What's your full
You
name?
should, sir.
I should.
Yes, sir,
Of
because
course.
we also are working for the same cause. So if you are
All right.
like,
I don't practice as such with patients, but personally, I'm a strong, not religious person, please. I'm a spiritual person. Okay. I started my spiritual practice in 1994. before entering into my master's in psychology. During my undergraduate in psychology, I started practicing spirituality in one of the important places in Pollachi, near Coimbatore. I achieved one important component in that. Then I explored some of the spiritual gurus, but I reached to a stage where the logical thinking, then we follow. Even in my master's, my assignment in Indian psychology, it was I practiced clinical psychology, but they asked me to take up a seminar on Indian psychology, where the topic assigned to me was about Osho. Okay, I visited Osho Center. I read completely about Osho's practice and how his spiritual connectedness, likewise Swami Vivekananda. So, of course, if we don't say that, I'm not a spiritually connected, I'm a highly spiritual person. I don't deny that. But it's a very personal thing to me. I don't club that with my practice.
Professor Surendran, could you also, if you don't mind, answer the question on where do you draw a line with some
I'm
of the,
sorry, can you make it louder?
if you don't mind, if you could answer my other question also, which is where do you draw a line between pseudoscience and some of the spiritual things that you have?
Yes. See, we need to be very clear. And today become, whether yoga, meditation, these are becomes like psycho-oncology. Everybody wants to become a psycho-oncologist. So without proper education and training. Um, Same comes to spirituality also. And you can't do something without a proper training. You must have somebody who can teach you. Okay. Of course, my teacher in my master's, he's a great psychologist. He used to teach me. And there were two professors. One is highly spiritual. Now he's a good meditator. They're all seniors in psychology I'm talking about. And the other teacher would say, "Hey, I'm sleeping, man. Sleeping itself is a meditation." He would say, "If you have a sound sleep, that's a good meditation. Why do you want me to do this meditation?" So this is again a debatable one. But when it comes to science, first thing is, in psychology, you must be a qualified person. There is no doubt about it. If you're offering psychological interventions, you must be qualified. Number one. When it comes to spiritual practices, whether it is meditation or yoga, nowadays there are courses available from a reputed institution, I would say. Okay. So you must yourself get trained in these aspects. If you are a Reiki professional, please make sure that you are properly trained in the Reiki. If you are a meditation expert, make sure that you adopt. There are so many meditations. Which meditation do you follow? You can't say that I do all this. And I remember one psychologist was talking to me, I am so and so, I can do anything. No, you can't do anything. You must be clear. Okay. So that understanding must be there. We must respect the science. If I don't know how to deliver CBT, I should acknowledge. I should not do injustice to my client. So that is where the science and the pseudoscience is very important. You have to yourself get trained first professionally, then offer. If you are incompetent, somebody you heard something somewhere, don't do that. Then you are going to do injustice to your patients. That's why the science is very important. And these are science nowadays. That's why even in spirituality, I said, see, spiritual well-being by European oncology, which means that what's a science? They want to assess. When you assess, then you should address. When you address, it should be scientific. So when do you say scientific? This many sessions, this many time, and do they adhere to that? Those are all the scientific practices that we need to follow. Yeah. I think I answered that question. I practice spirituality. Clarity and transparency about competence is very important. Yes, I agree with you, Aparna. I think the rest of the question I have answered, right? Anything left out? All right. 15 more minutes. I stop here. Thank you so much for your interaction. Very encouraging to see, in a virtual class, interaction is much important. I never accept virtual class because I met madam, so I agreed. I prefer to be one-on-one. So it's great. So who is going to present the case?
Indra ma'am, you have the access. Would you like to share the screen yourself or you want me to share and read through?
You could share, but I don't have access. So
Uh,
it
okay,
might be easier for you.
sure, sure. I'm sharing the screen. You can just read.
Hello. So I wanted to present this case. I have to say something right at the beginning that by training, I'm a historian and I come from a background of literature. So this is something I've had to teach myself. How do you look at these cases? This is a real case because I've dealt with a lot of people, friends mainly, who passed away from cancer. And so I thought I'll talk a bit about this particular case. So the patient is female, 42 years old. She has breast cancer stage 4, and by occupation, she's a school teacher. Her medical history is that she was diagnosed with breast cancer when she was 40, and she had radiation and mastectomy, and after that chemotherapy in an African country where she used to live, and she was given 2 months to live. She was told, you just have 2 more months. So she stopped working, and then she came to India with her husband and child to be close to her family. This is of an Indian origin family. In her first year in India, she was treated with chemotherapy again. She was able to look after her child, go on walks, attend parent-teacher meetings, etc. In the second year of her stay in India, after another cycle of chemotherapy, she became weak, her food intake reduced substantially, and after a PET scan, she was told that her cancer had metastasized. She was told that no further treatment was going to be helpful. At this point, she'd become very weak and she mainly stayed at home. And this is when her husband asked a local palliative care unit to send a priest. Now, the diagnosis, the patient herself was aware of her diagnosis and the kind of therapy she was getting. The family, of course, knew about the illness through doctors and relatives who were scientific researchers. The prognosis also in this country where she lived, she was told she had just 2 months. But when she came to India, she saw that she managed to live for more than a year, almost 2 years. And she was hopeful that even until she was told about the metastasis and that there was no further treatment. Husband, child, and family members continued with new forms of treatment, and they wanted to prolong her life as much as possible. Even when they were told the prognosis, they felt if there was something available, they would go with it. There was awareness of palliative care by the patient, but the family accesses only the spiritual dimension. They only wanted a priest at that point. And they thought that this is going to help. And they didn't, I feel from just studying it that they did get pain management medication from the doctors they knew through their connection. So they weren't wanting to access palliative care at that point, for that reason. So here is the 2 families, and the father of the patient had died in Africa itself, and the mother was living in India, had come back to India. They had 7 children, of which the patient I'm talking about was the youngest. And one of the daughters earlier had also died of cancer. Now, the 3 daughters who are surviving, of them, K and C both had breast cancer, and N had schizophrenia. So this was, the family. And later on, I mean, just to give you an aside, both A and K both died of cancer about 2-3 years later, the brothers. There's not much known about the husband's part of the family, except that there were 2 brothers and 2 sisters. The parents had died, and they had been in Africa for a very long time. They'd worked there. So, sorry, can you go back, please? Yeah. So there was also a special relationship between one sister and the patient and her daughter. And they looked after each other. Next. So the patient's husband is of Islamic faith. He had met his wife when they were both working in Nigeria. He has a stressful relationship with his wife's elder sister, Miss P, who's his neighbor in India and who's very supportive of his wife, Mrs. C. He gets on well with Mrs. C's 2 brothers who live in Canada and Nigeria. His siblings are in Nigeria. He has very little connection to India, but has brought his wife here so she can be close to her family. Mrs. C, the patient, is a Catholic and had married against the wishes of her parents. Her mother and 2 siblings live in another city. She has moved to Bangalore to be close to her sister, Miss P. She goes to meet her mother and sister, N, 6 months before she passes away, and her mother says she does not believe that this daughter has cancer. So there's lack of acceptance there. Miss P is a science researcher who also has cancer. Her network of friends and doctors are always at hand to help her sister, Mrs. C, and her daughter, G. They also meet and converse with doctors about drugs and pain medication. Mr. M approaches a palliative care unit for help with his wife, who he feels might need religious solace. The priest, who arrives 4 days before Mrs. C passes away, accuses Mrs. C of not being a good Christian and living in sin all these years. She is upset and does not wish to talk to him. Miss P is very upset and does not know what to do. So there's high stress. They're already coping with the death that is about to happen. And then there's this kind of stress that has come with the priest's visit. Mr. M attempts to buy a plot of land for his wife's burial a week before his wife passes away. He is not successful. Miss P is upset with him for giving up hope. Mrs. C gets worse. Her brother A from Nigeria comes to visit her. G, the child who's about 11 years old, is not told anything about impending death. When Mrs. C is dying, her husband panics and calls the ambulance, and the family convinces him that this would not help at this point. She passes away some hours later. The church sends 2 nuns to pray for her. Mrs. C is cremated, and her ashes are floated away in the river. Her child is comforted by the presence of her aunt, Miss P, and Mr. K, her uncle. A few months later, she and her father leave for Nigeria, where her father, Mr. M, rebuilds his business. So if I construct the eco map, then we see that, this family, they are strong in their finances. They're able to support this treatment. The sister and her network, that's also a strong connection. But daughters, friends, and family, religion, friends, the family friends, extended family, all these are not so strong. The doctor network is moderately strong. Palliative care, they access only for one thing. It's a little tenuous, and there is a lot of stress between the mother and her other siblings. Next, please. So if we look at the socio-economic overview, they live in a gated community in a 3-bedroom apartment. Mr. M and Mrs. C are spending their savings on treatment, living costs, and child school. Treatment for Mrs. C is carried out in private hospitals where they know the doctors through the sisters' network. Miss P, who is single, offers also financial support to her sister and niece, although she has ongoing cancer treatment. Mother and siblings in other cities seem unaware of the seriousness of Mrs. C's illness, and siblings do not visit. Mrs. C and her family have no friends in India. Mrs. C has made a few friends with the parents in her daughter's school, but she cannot socialize because of her treatment and illness. Mrs. C and her family have become part of Miss P's social network. Mr. M's family has remained distant and rarely call. So no psychological assessment of the patient and her family was done. Miss P offers emotional support to Mrs. C and her daughter. She does not get along with Mr. M, which creates tension in the family. Miss P's friends also provide emotional support to Mrs. C and her daughter. So if I look at the concept of total pain that was covered initially, then we find physically there's extreme discomfort initially from chemo, then pain after that she came with mastectomy, and of course the life-threatening disease, and of course the pain of cancer, which starts as she's dying. I mean, just some months before she has terrible pain. Psychologically, she has to manage stress between her husband and her sister. She cannot express when she is irritable, and she feels obliged to smile and say she's fine, and she's worried about her daughter. Socioeconomically, they're separated from their familiar surroundings. There's no network of friends, not able to talk to her mother or other siblings, and she's not able to participate in the child's school activities like other parents due to illness. Spiritually, she has had an interfaith marriage and does not know whom she can address, to whom she can ask so that she can address questions she might have. No support from sister and her network, which are mainly a scientific research background. They don't really know how to do this. And there's no support from religion, as we saw. So here are the things that, I wanted to discuss. I wanted to say this is a case where the patient has died. But if we came across something like this, how could things have been handled to give more comfort to Mrs. C? What could be done to address the psychological well-being and acceptance of the family of Mrs. C? What kind of psychosocial network could have been put in place for her, which could also support her and her family socially and nurture the family's interests and abilities? And what kind of non-religious spiritual support could be offered so that she did not have to spend her last days being sad and depressed about her life choices? What could have made Mrs. C's quality of life better? And finally, hypothetically, the plan I felt could be to have the full palliative team to undertake a home visit to explore more about psychosocial problems and practices that the patient could be initiated into, such as mindfulness, breathing. I haven't put yoga, but perhaps yoga, but she was in a lot of pain. And to facilitate counseling services for Mr. M, the daughter, also. So that's what I thought I'll present, and we can have the discussion points if there's time. We are already out of time.
Surendran sir, would you like me to keep the discussion points displayed or should I stop the share?
Yes, we can keep the discussion points displayed. So what do you suggest? Do you want to hear from other participants? What's their view on this so that I can give my comments at the end?
Yeah, it depends on Shri Priya. If there's time, then we can do that. Otherwise,
That's open to the audience. Like if anyone is having any concern or any points to share, maybe we can take up a couple of points before we hear your words, sir. I believe that would be fair enough. Any quick points which anyone would like?
It's a very interesting case to be discussed.
right. So I just wanted to know what the group thought of it.
Yeah.
And somewhere I think as a very middle class person, I have come across this denial in patients' families very often. It's not, this took place in a certain way, but I have seen it in other families too. And so I wonder if anyone has anything to share or to comment on these aspects.
No comments?
No, one thing I would like to bring out is when there is an interfaith marriage, the thing is what we take it for granted. We don't really think of what the end, what all the problems can happen. So I think the interfaith marriages, people should be very, very consciously aware of these things, and they should about which religion or ultimately everybody will have an end date. So then how do we go? These things, I think in the beginning itself, there should be some forum where they can, confirm what are the things that will be done. Okay, if a child is born, which way, if they have a, other kind of a social issues, where they go, whether they go to a church or they go to a temple or a mosque or whatever, or they go to some agent area where there is a, it is some like thing. So, because these things are very, although they are not very significant in reality, but these things cause a lot of mental torture to the families and to themselves. No, they don't know, and there's a lot of confusion created. So I think as individuals, we should be very clear about our religious, what do you say, to what we endorse. I don't know whether I'm making myself clear, because I have also come across many families where there was interfaith marriage, and when any problem like a ailment or a death or any other thing comes, they're totally lost. They don't know how to cope about it. And people around also don't know. They are hesitant to come forward and do anything because they don't know, in what manner they can help. So there is a lack of communication, or there's a close thing. There's no open communication here.
Yeah, here, this family lived without any religion. I mean, quite happily. It's only
as long as they lived, it was
death
okay.
came,
As long,
that's when all these questions came up.
All the problems come only when there is, all these things come only when there is a problem. As long as you're normally living, everything goes well, you understand what you want, all those things. But when you are incapable of understanding, when you are incapable of taking a decision, then somebody has to take a decision for you. So at that point, this becomes a real issue. I think this is something that all of us really need to discuss with an open mind. And when we approach any family where we are giving a palliative care, we have to, it's very sad not to go and ask a person when you die which religion you want to, what end rights you want. It's very sensitive issue, but still we need to talk and we need to bring out so that we can give them the right kind of end of life care. So as palliative workers, volunteers, we need to be open. We should never hesitate in go asking them, and getting out the information as to what kind of support that we need from be given to them. I hope that's my feeling. I just expressed.
All right.
Indira, I have a question on this. Why was the husband not open to other aspects of palliative care? I'm sorry if you covered it and I must have missed it.
Well, I see the only thing I can assume is because the pain, they associated it with pain management and they felt their pain management was okay. So they went and they said, he said, this is what we want. And I don't think he was even thinking about it deeply because his wife was not that way, very religious, but he felt he had to do something at that point.
So is it also that the patient wasn't involved in this kind of decision making? Did not have the knowledge, did not have the access, did not have the decision making power? Yeah.
Well, I think he told her and she said, I don't mind. It's okay, I don't mind. But, she was after that really very shaken and very upset with this.
Yeah, and Mary made such an excellent point. I was just thinking some of these things actually, your families blame them, you did that interfaith marriage, so now you have to suffer the consequences now, you will not get the support, and they try to justify their cruelty towards the patient using these things.
So, ultimately, whether you have a religion or not, you are a human. So it doesn't matter whether you are cremated, you are buried, you are whatever after you die. But while you are alive, you should get a right kind of care. That is what is important. So I don't know. This is one big issue.
So the death happened in India or it's in India, right?
It's in India. The death happened in India.
Any other questions? Any comments?
Do you have comments, doctor? I'd be interested.
Yes, I do have. I
Yes.
do have. It's a very interesting scenario where husband follows one faith. The wife is from different faith. And I don't know what the children were practicing, whether father's faith or mother's practice or which one they follow.
Neither, really.
Neither.
I mean,
So I remember you said they are not religious.
Yeah. So it was like though the child had a Christian name, she did go back and went to a school that was supported by her father's community. So it was, that's how they conducted their lives. They didn't really go into any religion.
But one thing which I noticed, there is no psychological evaluation for this patient. See, if you look at, just keep aside their inter-religious marriage, familial support, I agree with you that these are essential, no doubt about it. But generally, it is not cancer, any ailment for that matter. When someone is diagnosed with an illness, which is an incurable illness, where the person is going to live for a short span of time, which has been disclosed, that is definitely going to be very stressful. Okay. Whether the stress in the form of physical or psychological in nature, I would say 80% it's going to be psychological. Okay. The first thing anybody in that place need to look at it is the psychological state of that person. Okay. No, unfortunately, the social support is less. But considering Indian context, and today, if the patient is from Kerala, you got a very good network of palliative care, and the support system is available across the state. I'm wondering how come this can be missed. Okay. And the patient need to be assessed for distress, not just one time, it should be periodic. Because the distress, if you look at the distress continuum, the patient, if you address the distress today, it doesn't mean that tomorrow or day after henceforth she will be all right. There could be other possible factor which can trigger the patient to develop distress. So it should be assessed and addressed accordingly when it comes to psychology of that patient. Provided if this is taken care, the patient would have had a better quality of life or quality of death, because we started using the terminology. We conducted a study on quality of death, and I'm also one of my PhD scholars is working in this area, so that's why I'm telling. So then talk about the death and fulfilling the wishes, and her wishes to bury her in a place where it's okay, that is not achieved. Now there is a guilt on the other side also. So was there a chance to connect them with any non-governmental organization which is working in this line? In Chennai, there are many organizations, they do work.
This is more than a decade ago, almost 15, 18 years ago.
It's old.
But I have to also say, and this I have seen among my friends who are very educated, psychological counseling is not acceptable. They just don't want to hear of it. And it's only now that I find that, some people will say, yes, I have, I need a counselor, I need to talk to. But it wasn't there, they were just not wanting it. I mean, it was, I'm coping. And I'm
Agreed.
fine. I mean, she keeps saying, I'm fine. That is what the patient says, I'm fine.
Madam, this is very common, even in general setting, not about cancer or any dreadful diseases. General mental health, if you go and tell yourself you are a psychologist or a psychiatrist, they will immediately say no. Okay, that acceptance stigma associated with mental health is still there. Of course, I don't say it's poor, it is better than before, but whether we can be happy, no. We suffered when we came to Cancer Institute 2 decades ago. They never accept. And today the demand is more. We are not able to see the referral is increased. So this awareness comes over a period of time. I'm surprised 18 years ago, this patient, had no service, and it's very sad. But still, today, I think it's possible to address all these issues because the mechanisms are available. So we can assess their psychological concern. And also support means social support. It is not just the family. Please, we need to define it properly. The caregivers, primary caregivers are the family members. And the friends and other networks are caregivers too, supporters. So support can be defined by the care provider and the care seeker. When it comes to patient, if they say, no, I don't want, I'm fine with them, means they must be happy. In case if they're not happy, as a therapist or whoever is working with the client, they should identify the gaps and fill that. Probably here the role of a social worker will be very high, because this is not purely psychological. The need for community-based social work or hospital-based social work is very, very high here. That also need to be roped in. So it's a teamwork. It is not one person's work. It's a teamwork, and the team approach, both doctors, nurses, psychologists, social worker, community health worker, all of them need to work together in ensuring the quality of life of patients like this.
Doctor, that's very true. That's very true. And I was surprised that, they could ask only for one service in the palliative care unit. That was functional at that point, and that is what they were given. They didn't say that, no, we should come
Okay.
home.
Okay.
You know, that didn't happen.
Even today, if you ask a patient whether you want to be in a hospice or you want to be at home, majority prefer home.
Mm.
They don't want to be in a hospice in India. Whereas in the West, the data is different because there is no respect for elderly. Though we document-wise, they say that, but still it's very minimal. But here it's the opposite. So the bonding system, the culture, that really helps. Maybe to some extent, people do miss that in our country.
Thank you.
Thank you. Thank you, Aparna. But we are better in that compared to the West.
But one thing, doctor, this palliative care also, there has to be very clear definition of palliative care. What are the boundaries of palliative care? Does it really have a boundary? Can it go out to any extent?
Can I comment on that? Can I comment on that? All right. First, ma'am, we need to understand what is palliative care. Many think that palliative care is end-of-life care. No. Palliative care begins from diagnosis. Okay. So then what is palliative care? It is not just helping someone to die peacefully or alleviate pain. It is beyond that. So address the symptoms, symptom management, supportive care. What is symptom management? What is supportive care? So these two. So when it comes to supportive care, assess their psychological status, their social requirement, their logistics, everything put together. So the palliative care has to ensure from the day one of the diagnosis to across the continuum. That is one. And palliative care is not only for cancer patients. It is for all. Actually, it began with, I think if I'm right, HIV, AIDS or some other disease. Okay. Now it is practiced widely in oncology setting. This is one. Third, who can practice? See, now you and me cannot prescribe morphine. It has to be prescribed by the doctor. And the dosage has to be determined by the physician who is trained in prescribing morphine. That is their role. Okay. So then wound management, who has to do? What if I don't do proper wound management if I'm not qualified and trained? So there are certain areas where some of the people cannot work. They can work, but they cannot do that. In some area, for example, when it comes to the psychological assessments, and if the person is suffering from neurological problem, neuropsychological problem, if you want to do the cognitive assessment, neurocognitive assessment, if you don't know how to administer the battery, then that person cannot do that. And you need a person who is trained in that. Okay. It's not that if you are a palliative care professional, you can do everything. The requirement of the patient, even in advanced cancer, varies from person to person. So first is to be the need assessment of the patient. And you have to rope in the expert in according. So one person cannot deliver everything. That's what my concluding point.
Thank you for the class and for the comments. Thank you.
Thank you. Thank you. Thank you.
Thank you. Thank you. Should be a total team. A palliative should have a consist of everything.
Exactly. It's a teamwork. There should be, see, the doctor cannot come to the community, and there should be someone who should be talking to the patient, convey the message to the doctor, and if required, they can come in. And see, most of the time, they want to talk to somebody. There is nobody to listen to their sufferings. If there is someone who can listen to them, touch them, heal them, that's also required. It's not that only always pain management. That's why we say it's a team approach. Okay. So thank you so much. Thank you. If no questions, I think we can
Yes, we can
conclude.
call it a
Thank
day,
you.
sir. Thank you so much for joining us, sir. Thank you so much, because this was actually a postponed session and out of the schedule also, because normally we
Oh,
don't have a session on Fridays.
right,
But
right.
because this session was so important, this topic was so important, and even now there are participants logged in after we have shoot past 23 minutes, shows the importance of this. Yes, and thank you so much for throwing light on such a wonderful,
Thank you. Thank you so much. I
such
enjoyed
wonderful way.
interacting with you, meeting you all. Thank you so much. So
Yes, sir.
looking
We do
forward to
also look
meeting in some other
forward.
days.
Yes, sir. We also look forward to have you in more of our sessions.
Yeah,
Thank you so
actually,
much.
I should thank Dr. Sridevi ma'am also for inviting me and Sri Priya for coordinating with me. Thank you so much. Thank you, Pallium India, for
It was a real
inviting.
pleasure, sir.
Thank you. Thank
So,
you. Thank you.
thank you everyone for joining us, and we'll be meeting again on Monday with another interesting topic and one of our regular speakers. Till that time, this is Repriya along with Dr. Surendran signing off from the Tips Hub. See you in the next session, everyone. Till then, take care. Bye bye.